For more AUA podcasts, hit the subscribe button or find AUAUniversity on SoundCloud.
Hi, this is Vic Nitti, Chair of the AUA Office of Education, welcoming you to another AUA Office of Education podcast. Today's podcast is Chronic Orchialgia, an Algorithm for Successful Treatment. My co-host today will be Dr. David Shin. Dr. Shin is Assistant Professor and Vice Chair of Urology at Hackensack Meridian School of Medicine at Seton Hall University in Hackensack, New Jersey. Before I introduce David, I just want to go over some of our learning objectives for today. First, I'd like to just say that chronic orchialgia or testicular pain is a challenging disease to treat from both the patient and the urologist perspective, because the perception and resolution of pain is often subjective in nature. With a national trend toward treatment away from opioid use, it's important that clinicians utilize an algorithm focusing on non-narcotic use for medication treatment, as well as to be able to offer office-based and surgical therapies when medical therapies fail. So our learning objectives for today are to compare and contrast pathologic and non-pathologic etiologies of scrotal pain. Second, are to summarize the rationale for different medication therapies and incorporate an algorithm for treatment. And third, to distinguish between various surgical treatment options depending on the etiology. And that introduction was so nicely written by Dr. Shin. So David, I would like to welcome you to the podcast.
Well, thank you for inviting me today. I'm really excited to join you.
So I will just tell the audience that this was originally something that David submitted as an AUA instructional course for the annual meeting. And when I thought about it, I thought this would really be an excellent podcast topic. It would reach it's a problem that all urologists see on a regular basis. And I just thought it was really ideally suited for a podcast, and I thought it would reach a much larger audience. So I'm so happy that David agreed to do this with us. So we'll start out by simply asking for some definitions and the pathophysiology of chronic orchialgia.
Sure. So, chronic orchialgia is defined as kind of the intermittent or conscrotal pain that lasts greater than 3 months in duration and will interfere with the patient's daily activities. So, what's interesting, the pain will not just be localized to the testicle. I mean, it could also include pain localizing to the epididymis, any paratesticular structures, or even the spermatic cord. So when you kind of use this broader definition, the differential diagnosis for chronic orchialgia includes not only both, chronic etiology, but it can also be unresolved acute etiologies of direct scrotal pain, which includes like epididymitis, testicular torsion, tumors, obstruction of the vas deferens, varicocele, spermatocele, hydrocele, or any unintended injuries, following a vasectomy or hernia repair.
David, what about pain that is perceived as chronic orchialgia, but may not necessarily be related to scrotal contents? Is that possible?
Well, absolutely. And that's what makes this, challenging, because just because you think it's only related to the scrotum, it may be other reasons. Like, for instance, men can have scrotal pain from a mid-ureteral stone. It could be a vascular aneurysm, lower back pain, interstitial cystitis, prostatitis, pelvic floor dysfunction, or even an indirect inguinal hernia. So those are all things that could, lead towards scrotal pain. It's also associated with, psychiatric conditions like a somatic symptom disorder or even major depression. And then, like a medication such as amiodarone, which is used to treat cardiac arrhythmias. Now, that's something that we don't, deal with or see, but you need to be aware of, because it can cause sterile epididymal inflammatory syndrome in up to 11% of patients who are on this medication. So there are a lot of different reasons other than, scrotal content that can lead towards chronic orchialgia. At the same time, though, even though there are those possibilities, almost up to 50% of the time, there is no real reason. It's considered idiopathic.
Now, I know in other diseases, other urologic diseases and symptom complexes, we often will use the term idiopathic. But even in these idiopathic cases, is there a pathophysiologic mechanism for chronic orchialgia?
Well, yeah, there is. And I think, maybe I'll just go through what a pain process is. So first of all, when someone has acute pain, before and it becomes chronic, it starts in these couple steps. So for instance, traditionally, noxious stimuli lessens as healing progresses. Okay, and then this leads to decreases in perceived pain until finally there's resolution that's achieved. There's no more pain. But acute pain can also cause an increase in nerve sensitivity, which then leads to modulations of nerve pathways, and then ultimately, may lead to hypersensitivity and spontaneous firing. And it's this kind of altered or activated nerve sensation in and around the spermatic cord, which is considered to be the major factor in promoting, chronic orchialgia. So one potential mechanism for this hypersensitivity is something known as Wallerian degeneration. And that's characterized by, like, say, an autodestructive change in the nerve cell axon after injury that normally promotes regrowth and healing. But instead, you have this heightened immune cell response initiated by the neutrophils and macrophages, which causes this intense inflammation surrounding the nerves. And then that leads to this neural hypersensitivity. And, this was found in an anatomical study done by Paracottle and colleagues, this was about a few years ago, where they looked at men with chronic orchialgia, and they found that this Wallerian degeneration was seen in 3 specific locations, kind of to support this hypothesis. It was seen in the cremasteric muscle, the perivasal sheath, as well as the posterior perilipomatous tissue.
So now, does this type of nerve hypersensitivity have a typical or common clinical presentation?
Yeah, great question. So, this hypersensitivity kind of will show itself as, 2 conditions. One, something known as allodynia, which is the perception of pain from a normally non-painful stimulus, or hyperalgesia, which is an exaggerated response to pain, more than what you would be typically expected. And that then can result in a perception of pain occurring even months after, like, say, an injury has healed.
All right, so let's move to some some practical points. A patient comes in with what appears to be scrotal pain or chronic orchialgia. How do you start an evaluation?
Sure. So you start an evaluation like what we all do, right? We start with taking a good history to find out, onset, location, duration, character, severity, and, whether or not there's even an irradiation of the patient's pain to another location. So, with chronic orchialgia, typically you see a dull, aching, kind of persistent pain that occurs with this type of presentation. Whereas, like, say, something that's severe, intermittent pain, may be more indicative of something like epididymitis, orchitis, or even intermittent torsion. And what I do find is that if you use like a visual analog pain scale, like from 0 to 10, that can be a really useful tool to help qualify as well as, document the severity of pain. So you have both you and the patient something to refer to and look back to. I think it's also important to, find out what factors make the pain worse or better, right? For instance, many patients who have scrotal pain may experience worsening of their symptoms with prolonged sitting. So if that's the case, then you will advise them later not to do that, right? After taking a good history, then of course you want to inquire if there is any other history of chronic pain, injury, or psychiatric illnesses such as depression, which can be associated with this. You also want to make sure if there's any prior surgery that's been performed, like say anything in the scrotum, the inguinal region, the retroperineal, spinal surgeries, as well as trying to determine if there was even a history of prior vasectomy.
Is there anything that you focus on during physical examination? Any tips that you can give to our listeners when it comes to examining the patient with chronic orchialgia?
Sure. So, of course, you start, examining the scrotum, right? You have special attention, that's paid towards the testicles. You examine that closely, the epididymis, the spermatic cord, as well as the inguinal canal. And when you do that, what you're trying to assess for is not only, first, the most worrisome thing is, testicular tumor, a mass, but you're also trying to assess if they have inflammation or infection of the epididymis or the testicle, varicoceles, spermatoceles, hydroceles, or even if they have an inguinal hernia. Now, one tip I guess I could try to share is, let's say if the patient's pain is on one side, right? Well, you may want to consider starting the exam on the other side to divert their, focus or away from that pain, so that, one, you're trying to get a sense of what that testicle is, the good side, but then also it sort of braces the patient to know that, okay, they're now going to be examined. And of course, you want to make sure you tell them this before you do that, so that they're kind of prepared, because they're already sensitive in this area. And lastly, what's very important is to do a rectal examination. You want to feel the prostate, make sure they don't have prostatitis, as well as examine the pelvic floor musculature, because in about 63% of men with either chronic prostatitis or this chronic pelvic pain syndrome will report having scrotal content pain as well.
How about initial diagnostic testing?
Sure. A simple lab test I think we all do as urologists and are familiar with is starting off with a urinalysis and with a urine culture to rule out infection. Again, that's the main reason to do it. You can also order a semen culture, especially if you think that's the source of infection. A duplex Doppler scrotal ultrasound should definitely be performed. Again, you want to rule out or assess for any structural abnormalities, again, in the testis, the epididymis, spermatic cord. And lastly, a CAT scan or MRI really would only be considered if there's a history of back pain, associated with scrotal pain. So if you're trying to, see if they have any spinal conditions, spinal stenosis, or even if you're concerned about a kidney stone, that would be the more reason why you would do those type of testings.
So let's say the patient goes through that basic evaluation. Obviously, if you find something on exam or on testing that might be or you think is a cause of the pain, you'll go ahead and focus your treatment on that. But let's say lab tests and any imaging studies that you do that you deem appropriate or negative, and you don't have an absolute etiology for the pain. What initial treatments do you start with at that point?
Sure. So, I think, maybe what you're asking is, what are some kind of conservative management or things we can do easily can be recommended or started off with. And so, one thing that patients can do is that, well, they can either wear, tighter fitting underwear or a scrotal support for elevation, because that may help to relieve some of their pain symptoms. You can use either hot or cold compresses. It really doesn't matter which one it is. I think bottom line, whichever one works. So in that sense, patients can try to experiment one way or the other. And of course, lastly, if there's any activities that evoke pain, well, they should be avoided. For instance, we talked earlier about, prolonged sitting, sometimes is associated with this chronic pain syndrome. So, one thought is, just taking scheduled breaks throughout the day that may relieve pain so that it can sort of break the monotony of things. And then other kind of non-invasive things or I guess non-medication related things you can do is start with, biofeedback, acupuncture, or even pelvic floor physical therapy, especially if there is an associated, like say, pelvic muscle dysfunction that's been found on examination.
So it makes sense that we would start with conservative therapies. How often would you say conservative therapies help patients in your experience, where you don't have to move on past that?
Yeah, I think it really just all depends, right? It's, I find that it works probably about 20-30% of the time. Now it also depends on your patient population, right? If you're a referral center where you see, patients who've already been through a few people, then that percentage is going to go down. But I think for a lot of general urologists out there, they may be the first time person they're seeing this, the patient's their first time they're seeing these patients, that, I think these conservative therapies can definitely help, and at least it gives them some structure and knowing that there is, things that can be done if they haven't done that already.
And I would imagine that for some particularly younger patients, just some reassurance that there's not anything wrong. I mean, you would think young people are going to be particularly concerned about, testis cancer, et cetera. I would imagine that even that reassurance through physical exam and whatever testing that, hey, whatever this is, it's nothing serious. I would imagine that probably helps in a certain number of cases as well.
Absolutely. I think, our biggest challenge is especially with these young guys is that, that they are doing self-examinations, and that, I think if anything, we rather err on them being concerned and being evaluated than just not being concerned, right? So that in itself, I think reassurance is definitely very powerful.
Now, how about you've gone through your conservative management and they haven't worked? What's the next step?
Well, I think that's where once these conservative management therapies don't work, really the next step is, medical management, which would be, different therapies or medications.
What about, lots of times you see these patients have been treated with a course or multiple courses of antibiotics. Is that a reasonable thing?
Well, antibiotics are really only reasonable if there is an infection, right? So if there is something that's been documented either from an ultrasound or an examination, severely tender, epididymis or testis, again, also confirmed by ultrasound, then yes, antibiotics is appropriate, right? But as well as if you have a urine culture or something that states something positive. But if you don't have any clinical or radiological evidence showing infection, then really antibiotic therapy is not indicated and shouldn't be offered for treatment for orchialgia.
So where should we start? What's our first line medical therapy?
Sure. So, in terms of first line therapy for, pain control and management, the easiest thing is doing a 2 to 4 week trial of anti-inflammatories. Okay. And they could be a few things. Either one, you can start with ibuprofen, 600 to 800 milligrams every 4 to 6 hours, naproxen, 500 milligrams, twice a day, or even some of the non-steroidal anti-inflammatory medications such as celecoxib, 200 milligrams daily, as well as meloxicam, 7.5 to 15 milligrams daily.
Is there any one of those that you favor, or would it be different in different patients?
Well, I think the easiest thing is starting with ibuprofen. It's the most common thing that you can just get over the counter without using a prescription. And then after that, naproxen is also good. And then, the non-steroidals, either one is fine, the celecoxib or the meloxicam. I think, part of it is also dictated by, what insurance plans cover.
Okay, so how about if, well, before I ask you what to do if these don't work, how often would you say that anti-inflammatories give us significant relief of pain?
Well, I think it just depends on etiology, but a lot of times it will work. Again, it's a good first line therapy. Again, it starts, there's no data showing exactly, percentage wise in terms of like, okay, it works in 80% of the time. I think maybe in, clinical practice, again, it's a good starting point. Probably about, again, 20, 30% of guys will have relief just with that alone.
Okay, now moving on, anti-inflammatories have not given the patient significant pain relief. What's next?
Sure. So, once that doesn't work, then you're using other medications that may be off label. So, for instance, tricyclic antidepressants, such as like amitriptyline, which is 25 milligrams daily, or nortriptyline, which starts at 10 to 20 milligrams daily and could even potentially titrate up to 150 milligrams as needed. That would be, one of the therapies that you can use. And, the exact mechanism of action is unknown. I mean, that's been stated, but but it's thought really be to due to an inhibition of either serotonin or norepinephrine reuptake. So in other words, by having the elevated serotonin or norepinephrine levels in the brain, okay, it leads to further enhancement of inhibition of something called nociception, which is the sensory nervous system's response to harmful stimuli. So in other words, it leads to a decrease in perception of pain, and that's what these medications have shown. You can also use something called neuromodulators, such as gabapentin, which starts at 300, going up to 600 milligrams 3 times a day, as well as pregabalin, again, 75 to 150 milligrams daily. And the exact mechanism, again, is not known, but it's thought to be due to a blocking or binding of the calcium channels in the central nervous system, which then, reduces neurotransmitter release, and that again leads to this inhibition of the nociception.
So I got a couple quick questions. With respect to tricyclics, do you tend to like to give them at nighttime before bed to minimize side effects? I know I've done that in treating some pelvic pain syndromes, and it seems to minimize side effects. Do you have a preference for when the patients take it?
Yeah, absolutely. It's the same thing. We like to try to minimize side effects, and so using them in the evening is preferable. But of course we always have to be flexible. Like obviously, if it works better for patients in the day, that's not a problem either. But we start off in the evening, just like as you said.
And then another question I had as you were sort of explaining some of the proposed mechanism of action for tricyclics, and you mentioned norepinephrine and serotonin reuptake. Has anybody ever tried to use duloxetine for this, since it is a norepinephrine and serotonin reuptake inhibitor? Any experience with that?
Not that I'm aware of. I think, at least, and I think that's always been the problem or difficulty in this space, is that the literature on this is few and far between. But that's an interesting point and could be a very good study to look at. Maybe something I'll consider after this.
So my next question is, we went over a couple things: tricyclics, neuromodulators. Any studies to support their efficacy?
Sure. So there is one study that actually supports their efficacy for these neuromodulators and tricyclic antidepressants. This was published in 2007. Now, it was in the study of 19 patients. So already right off the bat, that's a small study, okay? But it's really the only study out there that shows its efficacy. In fact, about 62% of these patients who are on gabapentin and about 66% of those who are on the nortriptyline reported a 50% or greater improvement of their pain. So that's what we use as our basis for this. But as we just talked about, really, there really isn't that many studies out there, and I think that's if we could have that, that would be really helpful in terms of advancing just our understanding of the whole treatment.
So what about narcotics for the especially difficult and affected patient with pain?
Right. So the challenge with narcotics is that, they will work, of course. But they're really only going to mask the symptoms of chronic orchialgia, right? And it's not really treating the underlying conditions, okay? And of course, as you know, we're trying to minimize opioid use in the United States, and so this is really not something that would be offered, or I guess maybe the better way to put it, if it's at a point where someone is really having that much difficulty and pain, you're probably better off referring this to a pain management specialist, because this is where their area of expertise and can also assist you with this. So, so I personally don't really prescribe narcotics. I don't think, and if they are at that point where they need it, then I think we need to get some other specialists to help us with this evaluation.
Yeah, I can imagine that would just be an open window right to narcotic dependency. And of course, we'd like to stay away from that. Well, we mentioned in the beginning surgical options. What about what's the role of surgery in the treatment of chronic orchialgia?
Well, surgery definitely has a role, and I think it's something that you would only do after patients have failed conservative therapy and medication therapy. So surgery is not right off the bat, but it definitely is a role once you've started exhausting some of the more conservative therapies as well as the medications.
So let's talk a little bit about any further diagnostic tests before moving ahead with a more invasive or aggressive treatment.
Sure. So, before you're going to do any surgery, I think it's really important to establish, if it's a nerve issue or not. And so, typically what we recommend is having patients undergo a spermatic cord nerve block, prior to performing any sort of procedure, because not only will this be diagnostic, but again, will be helpful in determining whether a patient is a surgical candidate or not.
So can you take us through the steps of how a nerve block is performed?
Sure. So, this is usually done with an injection of about 20 cc's of a 50-50 mixture of 2% lidocaine and 0.25% bupivacaine without epinephrine, using a very small needle, 27 gauge needle. Now, the injection is done directly into the spermatic cord at the level of the pubic tubercle. Now, you could use an ultrasound if the patient's anatomy is somewhat challenging due to their body habitus or if they've had surgery before. So you can use an ultrasound to assist you with that injection. Now, after you perform the block, again, doing that injection, the patient's response really should be assessed. And it should be used with that, again, that rating scale, that numerical visual pain schedule that I think I mentioned earlier, because you have somewhat objective data that both you and the patient can refer to both before the block, and then you're going to ask them after the block how their pain control is. Now, if the spermatic cord nerves are involved in the pain signals, what patients should see is relief for the next 6 to 8 hours, because that's as long as the anesthetic is going to work. All right, and this is a good sign, especially because if the spermatic cord block is at least 50% successful in reducing pain, then we can talk about surgery as being an option. And I think interestingly, for those who experience, like say, more than really 90% pain relief, these cord blocks can then be repeated in the office every 2 weeks as needed.
So now, if patient has a successful or has a good response to a cord block and is interested in treating the problem surgically, what are the options?
Okay, so at first there are a few options. It just first depends on the underlying etiology, right? So, for instance, if there's a history of vasectomy, okay, about 1 to 2% of men who undergo vasectomies may develop, again, this kind of constant or intermittent, testicular pain that lasts for more than 3 months, and this is actually, usually defined or coined as the post-vasectomy pain syndrome. Okay, so now post-vasectomy pain, patients, who again failed conservative therapy, just as what we just talked about, then the next step is the microsurgical vasectomy reversal. And why it's thought to work is because, the pain from the post that's related to the vasectomy might be due to, like, say, a nerve compression of the spermatic cord, causing inflammation, or either back pressure, from, congestion of the epididymis, or, perineural fibrosis. Again, that's a consequence of the vasectomy. And when you do the vasectomy reversal, you consider also removing any sort of sperm granuloma, especially if it's, when you're doing your physical examination, it's tender on exam, so you can remove it at the time of the vasectomy reversal. Now, of course, anytime patients undergo surgery, as you know, they have to be counseled appropriately. And, what I do tell patients is that, this isn't 100% guaranteed, right? In fact, the success rates on vasectomy reversals for these types of situations with post-vasectomy pain syndrome has been reported really anywhere between 50 to 69%. Okay, so it's good, but it's not perfect. And obviously, the biggest drawback of doing a vasectomy reversal is that you are potentially restoring back the patient's fertility, the whole point of why they did the vasectomy to begin with. Now, what's also interesting besides a history of vasectomy is that, varicocele are found in about 2 to 10% of men with chronic orchialgia. And, again, etiology of why this occurs is not completely understood, but it's thought to be due to, again, compression of the, kind of nearby neural fibers by the dilated veins, as well as kind of increased scrotal temperature, oxidative stress to the testes and testicular, ischemia that's kind of secondary to the vasal, to the varicocele, stasis. Now, again, what are success with this? Partial or even complete relief of pain symptoms, after varicocele surgery is really good. It's reported anywhere between, 72 to 94% of men in various studies. And what's really interesting about that is that it didn't matter what the approach was. Okay, so in other words, if you did the surgery as an inguinal approach, subinguinal approach, retroperineal, laparoscopic, microscopic, or robotic, this was the same range. So it didn't matter how you did it, as long as you did it for the purpose for pain control. But of course, that being said, anytime you counsel patients, they always have to be aware, and it's been quoted in the literature, that there can be at least an 8 to 10% risk of persistent pain even afterwards.
So David, I have a quick question for you. In the patient with chronic orchialgia and a varicocele, will you take them through all of the less aggressive options that we spoke about first, or if there's chronic orchialgia, let's say it doesn't respond to a non-steroidal anti-inflammatory, will you skip those other things and go to a varicocelectomy? So sort of going outside of the algorithm that we just spoke about, or do you kind of stick to the algorithm?
Sure. I think, like with algorithms, they're there to help guide you, right? And so it just really depends on your discussion with the patient, right? It's as you all know, as we all are very familiar with, this shared decision-making process. So, first and foremost, before, even if they have a varicocele, I do, offer them, and I want them to undergo conservative therapy first, because that may work, right? And it may work in about 20% of the time. Whether, again, it's just doing some sort of modifications in terms of wearing underwear and whatnot, or taking ibuprofen, non-steroidal inflammatories, and yes, I would still even offer them the neuromodulators or the tricyclic antidepressants, because again, that may be because it's maybe a way for them not to undergo surgery. I think it does twofold. One, it shows that you've exhausted everything you can, and that two, patients understand that that you're trying to do everything before you get to surgery. And then lastly, of course, you get to the surgical portion of this. And I think when you do surgery, you want to make sure that you do it all for the right reasons, and especially if you just sort of go right into the varicocele surgery, you run into that risk of still persistent pain even afterwards, and that may be because it was more of a neurologic nerve issue and not necessarily the varicocele in itself.
So is there a role for cord blocks in patients with post-vasectomy pain, or in patients with varicoceles, or is the cord block more useful in cases of idiopathic pain?
Well, I think the cord block is definitely useful. I mean, not only for idiopathic, that's for the primary reason, but even in the situations where there is post-vasectomy pain or varicocele, you want to know, is there a nerve issue or not, right? Because if they respond to that, then one can consider, again, like say with the varicocele, for instance, right? At the time of varicocele surgery, you also consider doing a microsurgical denervation, at the same time, right? Versus, like say, with the vasectomy, a post-vasectomy pain syndrome, then if patients do respond to that nerve block, then they have options, okay? Because the option may be one, okay, go ahead and do the reversal, or two, instead do the microsurgical denervation, and that way you're sort of treating that condition while still maintaining their sterility.
Okay, let's move on to the idiopathic patient. you had been speaking about microsurgical denervation. So I'm guessing that's one of the options. And if so, can you tell us a little bit about how you do it?
Sure. So, with the idiopathic patient, yes, then there are definitely excellent outcomes that occur with the, what's called the microsurgical denervation of the spermatic cord. Okay, and patients who have again a greater than 50% positive response to the spermatic cord tend to do well with this surgery. So, so I guess the question, how do you do the surgery? So, first, in the standard microsurgical denervation, the procedure is usually done either through an inguinal or subinguinal incision. The spermatic cord is identified and the ilioinguinal nerve is isolated and transected. Okay, and then afterwards the spermatic cord is delivered up out of the incision site. Now at that point, then you bring an operating microscope, or you use robot-assisted technology, and the external spermatic fascia is open anteriorly, exposing the underlying cord contents. The cremasteric fiber is identified and transected carefully to preserve the cremasteric artery. Next, all the veins and the microsurgically visible nerves are ligated and divided, and you're only left with the testicular and the deferential arteries, lymphatics, as well as the vas deferens that's intact, because especially if you want to preserve fertility. Now, interestingly, what's also you do is that you do the fascia around the vas is strip free and divided for a length of 2 centimeters, because again, 50% of the spermatic cord nerves are located in close proximity to the vas deferens. Now, a variation of the surgery is something of a more targeted approach, where only the cremaster muscle fibers, the perivasal tissue, and the posterior lipomatous tissues are transected, while you're still preserving the internal spermatic sheath, and that includes, the testicular artery, veins, and lymphatics. And hydrodissection of the basal sheath is also performed because, again, this ensures the ligation of the neural tissue that's around the vas deferens without actually injuring the vas deferens or its corresponding artery. And, the basis for this kind of alternative approach, this targeted approach, is again from the Wallerian, nerve generation that was observed again in the cremasteric muscle fibers, perivasal tissue, and that posterior lipomatous tissue. And, in one series, 83% of the cases had, again, a significant reduction in pain after this targeted approach. And it's very similar to, again, the success rates that's been reported for the standard microsurgical denervation of the spermatic cord.
What kind of complications do you see with microsurgical denervation?
Well, other than, I guess, hematoma, wound infection, and of course the procedure failing, the specific risks associated with the procedure include either, like, say, hydrocele. Now, that occurs less than 1%, and that really only occurs if you have damage to the lymphatics, and so that's why you try to preserve the lymphatics during this procedure. I guess another potential complication is testicular atrophy. Again, that's 1%, and that would only result if you have injury to the arterial supply going down to the testis. But overall, this surgery is low risk, and again, is typically performed as an outpatient procedure.
And lastly, I guess we would be remiss if we didn't talk about orchiectomy or epididymectomy as a definitive treatment option. Yes. My first question is yes, and I guess my follow-up to that would be, if yes, how often do you get to the point where you do either of those two procedures?
Sure. So, either an orchiectomy or an epididymectomy is really considered last resort. Okay, it's because the success rates are really varied. It's as low as 20%, and even, I guess, as high as 70%, depending on which study you read. But even that in itself, what it shows is that you can remove an organ and you can still have pain afterwards, and that's it's one thing if it's going to work, right? Then it's risk reward. But it's even worse if you're now taking an organ that's benign, not for cancer related reasons, and yet patients are still symptomatic afterwards. So really, it's really last resort. I tried not to do that because of the mere implications of just losing that testicle just for pain control.
What about the scenario of, let's say, an older man who has what, based on your exam, basically has a chronic epididymitis. The epididymis is clearly the culprit. It's clearly tender. He's been treated with multiple courses of antibiotics, anti-inflammatories, etc. Is that a more appropriate place to say, we're going to do an epididymectomy or even an orchiectomy?
Well, I think, again, with, as long as fertility is no longer going to be an issue, and even though he may be older per se, you can never assume anything, of course, right? But let's just say, for argument's sake, that you're right, fertility is not the issue, and that he's really looking for something definitive. Well, then, yeah, you may lean towards doing something like that as something that can be helpful. Again, I think a lot of times, in this space, these patients tend to be younger, and so that's why, the orchiectomy or epidydymectomy really is not, again, would be more last resort for those folks. But again, it's something that, again, when you have that shared decision-making process with yourself and the patient, that is a consideration, and something to think about.
Well, you've done a really nice job of giving us treatment algorithms from conservative treatments, medical treatments, all the way to surgical options. How about alternative therapies or things that may be coming in the future?
Sure. So there's only been a couple things that's been reported in terms of alternative therapies. I guess maybe I could discuss here. So, first there's something called pulse radiofrequency ablation of the genitofemoral and ilioingual nerves. That's shown some promise. It was just recently published in Pain Physician in 2018, where 70 patients were randomized. Now they had chronic post-surgical orchialgia, so they had some sort of surgery-related testicular pain, but they were randomized to either this radiofrequency ablation versus sham. And they found that there was significant improvement in pain scores as well as a decrease in need for pain medications in this treatment group. Another alternative is something called salvage ultrasound-guided targeted cryoablation of the spermatic cord. And again, this was conducted in men who failed the microsurgical denervation of the spermatic cord. And what occurs here is that the branches of the genitofemoral nerve, the ilioingual nerves, as well as the inferior hypogastric nerves were cryoablated, both medially and laterally to the spermatic cord at the level of the external inguinal ring. And in this study, about 221 patients, again, recently published in Urology 2019, showed a 75% reduction of pain. So again, that's something, the question is now that's for salvage, but is that something that may be done for primary? And I'm sure, the authors are looking into that right now. And lastly, something called transcutaneous electrical nerve stimulation performed in the suprapubic region, where again, it's just nerve stimulation, I guess, of the nerves leading towards the testicle. When it was used with pain medications, it was shown to significantly improve visual pain scores and quality of life, and again, in a small randomized controlled trial of about 70 men. So
that's like using a TENS unit in the suprapubic region?
Yes, exactly. TENS unit in the suprapubic region. Yes, exactly. I guess the question is, will these therapies work out and be viable for, men with chronic orchialgia? I guess, that'll be another podcast one day.
All right. Well, David, this has really been a comprehensive discussion. I just wanted you to give our listeners some of your final thoughts or advice.
Sure. I think first and foremost, it's important or helpful to be systematic in your approach, because it makes sure that the patient, because this helps the patient understand why you're being methodical about the way you do things. And hopefully I've given some data here to sort of back up why we do the things, so it makes sense. It doesn't seem like we're doing things randomly. Now, obviously, what we presented today doesn't guarantee success, but it hopefully will help urologists have a better framework, in terms of how to treat chronic orchialgia, as well as to help ease, patients' anxieties and frustrations that are associated with this condition. And I think also importantly is that during any point of treatment, you really shouldn't be afraid to engage in any of your other colleagues or specialists, such as pain medicine specialists, neurologists, psychiatrists, psychologists, or physical therapists, to help out provide any additional care.
Well, that was really terrific. Dr. David Shin, who is Assistant Professor and Vice Chair of Urology at the Hackensack Meridian School of Medicine at Seton Hall University. Thank you for really an excellent and comprehensive podcast on a topic that we don't often discuss, but something that most of us and most urologists see on a regular basis. I would also like to thank the audience for listening. And as always, for more information, you can visit us at auanet.org/university. Thank you.